second. Thanks again for accepting the invitation, by the way. So
my pleasure.
Yeah.
Thank you for having me. So hello, everyone. Welcome to today's talk, which is about specifically about medical education in Lebanon. Thank you for Dr. Thoraya Araisi for attending. Dr. Araisi is a very important figure in medical education, and she's a mentor and a very dear colleague. And to some, I see some of my previous students, Raya and Rajiv, and a very dear friend, and also she was my classmate during the master, Sonia from the Netherlands. Hello, and welcome everyone else. Nice to meet you virtually. I hope you enjoy the talk. So without further ado, I'm going to begin with this presentation. And disclaimer, when we say business of saving lives, we don't only mean physicians, doctors, we mean also, we mean equally, nurses, social workers, pharmacists, people in the realm of nutrition, administration, everybody who works to make things happen in hospitals and in clinics. So that just I'm clear, my area of expertise is in medical schools. These photos are from Google, by the way. I did not mention it, just from Google, nothing special about that. So medical education in Lebanon. So I don't know if some people might know or might not know, this very small country, which has a population of Lebanese people, not counting foreigners or refugee populations, around 4.5 million, has a total of 7 medical schools who are acknowledged by the Ministry of Health and the Ministry of Education and Higher Education. So do you have an idea, anybody, how many graduates, medical doctor graduates does Lebanon produce per year? I don't want to sound like I'm lecturing, so I would like people to try to guess the number, and then, so do you usually do that with your talks? Because I don't know. Do you allow that?
Yes, feel free to do whatever you want. Yep.
Yeah, so if people would want to guess, maybe they can enter it in the, I don't know if you have a chat here somewhere.
Yes, there's a chat and they can answer. So if on average, I would say if there's 100, 700 per school, in total, maybe.
Yeah, something like that. So we have 7 medical schools, average of 600 MD graduates per year. And then you have people who get back to Lebanon. So they've done their MD maybe in Syria, maybe in Russia, maybe in Romania, in France, I don't know. And they come back here to do their specialty. Sometimes it does happen. And some of them even, but on rare occasions in the UK. So for them to be able to do their specialty, there has to be programs for that, for various kinds of specialties like internal medicine, surgery, pediatrics, dermatology, you name it. So let's say we have these 600 graduates, and then I don't have a number for the people who, the MDs, the Lebanese MDs who come back. And the available spots for these fresh graduates are around 300. So when we say here PG1, it's postgraduate year 1. So I would like to thank here Dean Nadim Cortas, who helped me kind of do this estimation of a figure, because we don't have formal data, which is another big, huge topic in Lebanon. We have a lot of dirty data, scattered data, nothing well organized or present in formal manners and from official bodies. So you see here, there's this discrepancy between the number of applicants, although not all of them would apply to stay in Lebanon, and maybe not all of them would want to pursue clinical medicine, but still the available numbers of residency spots is quite lower. And it's okay. I mean, not all of them stay in Lebanon. A lot of them do apply to go abroad. So here are the numbers, and I got this from a study back in 2012 by Nemer et al. So total number of students So the 4 years, if we're speaking about the American system, but also the French system, which is a total of 6 years, which is an USG, BAU also, and Lebanese University. Oops, sorry. So we have a total of 24 medical students, okay? So on average, this is all the years from Med 1 to Med 6 or Med 1 to Med 4. A number of graduate students, this is different. This is from, other programs. Now, if we look at first year, okay, so, and this was in 2012. So probably by now, because a lot of schools have grown up in size. So 600 is the right estimate. So we have 526 in the first year. And compared with Jordan, it's close with, and much larger countries like, France, first year is 1,200 or 1,300. So you can see, you can appreciate how many we matriculate per year. And this really poses the question. So we matriculate around 500 or 600 students, but then we offer half of that figure residency spots. So the purpose is to have a pipeline to send them abroad. So that would make sense. Otherwise, where do they go? Here from a report that's posted on the website of USG. So the evolution of working licenses in medical and paramedical professions between 03 and 08. So as you can see here, medicine, which is, I don't know why they're all in blue, but this is, I think, it. So it's fluctuating, but it's kind of stable. So despite the challenges, still a good number of people apply to medicine, which means that there's more also competition, which is a different topic that we'll not tackle today. So in 2004, and according to Aql et al., about 40% of those who had graduated from Lebanese medical school over the prior 25 years were in the US, okay, from all medical schools in Lebanon. 40% of them end up in the US. Lebanon ranked second after adjusting for country population size among the countries from where international physicians practicing in the US graduated, indicating a high migration density. So why are we talking about this now? All of us are aware of what happened recently in Lebanon. It's not just about the COVID and the decline in economic, socioeconomic conditions that occurred, COVID, and with the whole problem with the financial engineering that we're paying the price for now, but also the blast that happened in the Beirut port in August of 2020. And this has resulted in a wave of physicians leaving, whether to the US or to the Gulf countries. Some of them coming from very well-known medical centers. So again, there were efforts to reduce these this figure here, to bring back, and what they called it, reversing the brain drain. So these people who went abroad to get better training, to become board certified, to get a more sophisticated experience, we wanted them back to serve the people here in Lebanon. However, after what happened, I mean, whatever we reversed, I think it's gonna be the same. So this is not gonna change, and I don't know if it's gonna be even higher. So this is a study by Takian and Boulay in 2015. So this is the most recent study in medical education. And here ECFMG is the institution that, or not the institution, the organization that medical graduates apply through to the US specifically. So as you can see here in Lebanon, there's a total of, from 1998 to 2012, around 2,400 applicants. Okay, and comparing to other countries, it's comes third after Egypt and Syria. So we have quite a bit of graduates who go to the US, or who apply actually to the US. Here again, from the same study, They're showing the contribution of Arab-educated physicians in the US workforce. So Lebanon ranks still third after Egypt and Syria. Now, this is from a report, or actually from a, yes, it's a report by Dr. Walid Ammar, who was looking into the healthcare reform and healthcare system in Lebanon. So according to what he wrote, that during the 1990s, the number of physicians was growing by 8.3% per year in Lebanon, in comparison with a population growth rate of 1.6%. So we can see already this discrepancy. So there were a lot of physicians compared to the population that they serve. And the number of registered physicians in 2010 was around 11,780. 70% of these were specialists that were registered in the two orders of physicians. For those who don't know, in Lebanon, we have two orders of physicians, one in Beirut and one in the north. And 10 to 15% of registered physicians did not practice. So these people probably, they went into administrative positions, or they worked for pharmaceutical companies or consulting companies. And this is becoming probably a bit of a growing trend. We see MDs who choose different pathways, not necessarily a clinical practice. So a discrepancy exists in the distribution of physicians across regions. So despite the fact that we have a lot of physicians, the distribution is defective. With a higher proportion in Greater Beirut area, where the rate in Beirut was the highest in the region. So physician to population ratio, what does it look like? In Beirut, we have more than 6 MDs per 1,000 inhabitants. But in Beqa, on the other hand, we have less than 2 MDs per 1,000 inhabitants. We still have underserved areas, despite the fact that we have too many physicians in the country. What about hospital beds per physician? And there's, in Lebanon, there's less than 1 hospital bed per physician. So competition, again, this is a fertile ground for unhealthy competition between physicians to attract patients. And this also reflects onto the status of the medical education. So if I am a physician who works for Hospital X, and I have residents and medical students, and if I don't have enough capacity to admit patients, how can I teach these students? How can they train? In most countries, 2 to 3 hospital beds per physician. This is the ratio, according also, again, according to Ammar 2003. So supply of physicians in Lebanon compared to other countries. Physicians per 100,000 populations. So we can see here, Lebanon, we have 248, as opposed to, okay, so we have higher here in Germany and France, but still, I mean, for a country as small as Lebanon, this is very impressive. And this is a study by Dr. Kasak et al. In 2006. I think this has increased since then. I'm not sure though. Yep. Okay. So back to another study by et al. In 2008, a total number of physicians registered with the 2 orders of physicians from 1977 all the way to 2005. And you can see there was a steep increase here in the 90s, which was mentioned in the above previous slides, in the 1990s with that 8-point-something growth. So here it is. Number of physicians newly registered with the 2 orders of physicians. So again, there was some fluctuation here, but then the growth was significant, I think, when, you know, I don't know if we can associate that with, please don't hate on me, Taif, and the resolution of the prolonged war. Could be that, I don't know. And here by muhafazat. So in Beirut, you see the number of specialties in total, it's 2,800 almost. Mount Lebanon is 3,000, North 1,000, South 1,000. Beqa is also the least catered for, although Beqa is huge. So again, we have that problem. Another bunch of figures to show that registered physicians and the order, Beirut Order Physicians by country of graduations in 2001. So people who graduated from Beirut, okay, this is the number and percentage, and they were registered. And compared to people coming from, you can see they graduated Eastern Europe, Western Europe, Arab countries, North America. So if we sum these up, they're even higher than the ones that graduated from Lebanon and registered in the Order of Physicians. This was from 2003, again by Ammar only. Just to give a reflection, yani, about the population of physicians that we have and where they studied and where they're coming from. Now, oops, here, this is probably something that people might not really appreciate, but at the end of the day, although medicine is a humane and very much vocational choice of career, but at the end of the day, you have to put bread on the table. And I put this at the very end because this is not the purpose of it, but one needs to think about it. So average monthly income of graduates by region of education in Lebanese lira back in the good old days, and this is from 2006. So in Lebanon, the mean is like يعني مليونين و800, so 2,800,000.
LBP.
LBP, the LBP. Okay, so if you graduated from Lebanon, okay, this is how much you make per month. If you graduated from the Americas, you make twice as much. And this also gives you an idea because mainly physicians who come from the US, they end up in larger medical centers that have accreditation and that have higher standards, and they don't go mainly into private practice. Few of them do that. Usually they have, they are tertiary care centers, they are referral centers, so they have a larger population of patients, hence probably explains the income. This is from 2006 by Kassak et al. Sorry. This would be my last slide. I'm sorry if you have so many numbers, but we can go back and forth now if anybody has questions in this regard. And we can discuss the figures. And mind you, we don't have a local body that collects data from the various medical schools and does the examination of how many are there in the pipelines, how many residency programs are there, and the capacity of each residency program, and the progress of accreditation. Here, and speaking of accreditation, I need to mention that residency programs need to be accredited because by the time, by 2023, if either a medical school or a residency program is not accredited, people cannot go abroad and continue their education or training. So as far as I know, and I'm not sure about other residency programs, in the AUB, they had the ACG-MEI accreditation, which comes from the US, but it has an international chapter. And the medical schools, 2 or 3 out of the 7 are now accredited. The rest are either not accredited yet or in the process of acquiring the accreditation. And this is essential. And I don't know how things have changed or, they slowed down given the circumstances. And the latest piece of news about people wanting to apply abroad for residency training is that medical schools, for you to get into a medical school that follows the American system, you need to sit for an exam called the MCAT. And unfortunately, this year, we don't have MCATs in Lebanon. The centers, they stopped them. I think it's because of COVID, and they will not allow any Lebanese medical applicant to fly somewhere else to sit for the exam, which puts medical schools at a very uncomfortable spot, because they need to find alternatives for that, either forfeit the whole MCAT thing or do a national exam, which I doubt is possible, but yeah.
Can I crack a very bad dad joke or not? Prayers do come true afterwards.
Oh, goodness.
All the hate on the pre-meds has come to fruition finally.
Why do you hate? You shouldn't hate on pre-meds. They're just, they're part of the system. They don't produce the system. They're just consuming the system, I guess.
This is so Pierre has a question, and I'll tell you why all the hate on the pre-meds. But Pierre Haj has a question about statistics per specialty. But before we get to that, because you're just saying that this is the problem maybe of not only Lebanon, maybe almost everywhere, right? Everyone, like why would we want to admit more students than we are capable of accommodating after all, right? It's we have 800 graduates, and then we say, of course, some of them end up leaving, some of them decide to stay, some of them end up working elsewhere or choosing a different industry. But why don't we even take that into consideration? Because there's this, maybe it's a Lebanese, maybe it's a regional thing, maybe because it's their gateway to leave the country, some of them. There's this, everyone wants to do medicine, whether they understand it or not. And they are not really aware sometimes of the outcomes, of the consequences of what it takes for one to become a medical student or a medical doctor. And at the end of the day, you're saying they get paid at the 1,500 rate. That's like at most 60K, 70K. It's like, this is a shitty number for someone who's paying 24, 30, 35K a year for 4 years to just, so it's like, it doesn't add up for me. There, on the one hand, the administration, or how we administer the medical education, and on the other hand, those who want to get into medicine themselves. It's like, there's something missing there. I don't know what it is. So I don't know what you have to comment about that.
I'm going to begin with the culture. You cannot deny that MD confers status and prestige, right? I remember back when I was a Medicine 1 student, which was in 2004, one of our professors told us, "You are the crème de la crème." And I think this was, you were, you are, selected very well to enter one of the most highly rated medical schools in the region, which is true. I mean,
but of course.
It is. I mean, no. Let's speak facts. I'm only saying facts, right? Then again, you don't choose a career like medicine for the prestige. If you do that, you're going to end up either hating it or failing at it. And if people don't realize that, they will down the line, down the path, right? So the prestige it is true. And as far as I remember as well, and this is from recollection, that the competition was so fierce to get a spot in that specific medical school. And I always wondered why. I mean, okay, I know medicine and I know AUB and I know everything. There are also other excellent medical schools in Lebanon, like USG and to a lesser extent, maybe other schools. But I mean, I'm speaking about the quality of physicians. It's also maybe an avenue for people who want not only status in the society, but also status in seeking political positions at some point. So, you become well connected. And this is only personal analysis and observation. These are good schools. They invest in accreditation and having quality education. But I'm speaking about people who enter these schools. What do they have in mind? So this is just an observation on my side. So just make sure people, when people quote me on it, they know that this is not something I read somewhere or I'm quoting anyone else. That being said, I think they've done some studies, which I don't have right now, but I'm just from the top of my head, about the motivations of people entering medical schools. And we have a good number of people here in Lebanon, at least. It's like, my mom and dad are physicians, so I'm going to be a physician. You know, it's like 1 + 1 = 2, just like that. It's more, I know families who are physicians, you know, the mother and the father and all the children do medicine. It's like a tradition. So we have that. Now, what are the numbers? I don't know, but it would be interesting to know. Besides that, yes, a lot of people want to leave the country, and it's a good way to have a degree from a respected institution, and try to go abroad. And because when you go abroad, obviously, your degree from abroad translates into better income later on. These are my explanations of why people want to go into medicine. Besides people who really love medicine as a humanitarian and humane service. At the end of the day, medicine in its nature, it's a service, and it relies so much on service learning. So you render the service to the patient and you learn while doing that. Do people really get the gist of it as I just explained it? I don't know. I cannot speak for everyone. Some people do, some people don't. And this is something you can pick at and pick up along the lines. So when you're dealing with these people who have already entered medical school, and then when things, your relationship evolves with them, you can tell those who are very much about the patient, serving the patients, going above and beyond their ascribed or prescribed duties, just to make the patient experience optimal. And these are, they still do exist, and they can be it's very refreshing to have them, but this is not everyone.
Yeah. And partly, as Pierre pointed out, like I don't know about Europe, maybe because in certain areas there are a lot of vacancies and there's shortage of medical doctors, so there's less competition there. So maybe competition is also driven by the fact that the market is oversaturated up to a certain point.
Absolutely, and you know, because there are limited spots.
But not so limited as to take into consideration the fact that they are going way beyond what the market can afford to accommodate.
Mm-hmm. Yes, exactly. So eventually, not everybody can go reach where they want to reach. But for me now, because most of the students now they aim to leave the country, so the competition happens before entering medical school, during medical school, and then with the whole globe, for getting high grades on their exams for, you know, whether the USMLEs for the US or other for, you know, I don't know what they sit for when they apply to Europe or to Canada. So the competition is just, it's like your shadow that follows you, and you really cannot get rid of it. And this goes against what we're trying. I mean, the latest movements in medical education is to establish what it's called the framework of competency-based medical education. So when we say that, what do we mean? So I'm competing against the standard. This is the standard that I'm supposed to be at, or the level. And this is me, and I'm competing with myself, and I'm just measuring what's my capacity and how much effort and deliberate practice do I need to hit the mark. But I'm not competing with others. I'm competing with the standard or benchmark.
Yeah.
This is how it's supposed to be. But then again, this system it's so ambiguous with these mixed messages it sends. So you want competency-based education, or do you want the people just to be at this cutthroat competition? What do you want from them? And I get that frustration from students. They don't know. They get really confused, and I don't blame them. I don't know what the solution is, but this is how it is for now.
Yeah, I think I don't know if I pronounced Sonia, if I'm not mistaken.
Sonia, yes, Sonia.
Saying we see this at my uni as well. Some study optometry just for the status that comes with it. These are often the students who struggle the most.
Yeah, because they're not at it for the sake of it. They're not there because they love biology, they love human biology, and they love also serving people and helping people. Because, you know, being a physician, what does it mean? You are empowered with knowledge and skills, and you are sitting there, and sick people come to you. Sick people are, it's like, you know, you're well, you're normal, you're healthy, you have the knowledge, you have something to give them, and they come and they want something from you. They need something from you. And that power relation, really, if you don't level down yourself to that sick person who's coming to seek your help, you're not a good physician. You're not. You're just someone who knows their stuff.
I have a question there, but first, so going back to Pierre's question, if there are any statistics per specialty, and many specialties and subspecialties are already saturated in several parts of Lebanon, the issue becomes competition. New fresh comers from abroad will have their wings cut by already established HCPs by fear of competing, their chance to fly. But yeah, so I don't know if you have anything to say about
yeah, I don't have numbers. I really don't have numbers. I would like to dig further into that. I might not have, I mean, this is a limited search that I've done. So probably if I've done more research about this, I would have had collected more data as to how many people go into surgery, into internal medicine, and even the subspecialties. And then, yes, when people come back from abroad and there are well-established physicians, and this is something you hear, that, okay, there's a well-established surgeon, let's say, and he doesn't want any competition. So he gives the newcomer a very hard time. You hear that, you kind of know stories from here and there, but do I have numbers to prove it, to support this? No, I don't. But I'm going to work on it because it's an important question to answer.
Yeah, it's interesting. So the things I always think about are related to this. It's where would competition stop versus how would you, like, it's, as you said, you're trying to help sick people, and then it becomes all about some of them see it as a money-making career. Not so much, it seems, in Lebanon, no? Or I don't know.
Well,
and not anymore, because I've heard so many people leaving now. What's the how's it like? Everyone is, well, perhaps, yeah.
First half of what you've mentioned about competition, some schools, including UB, what they've done is to reduce competition and to try to instill these values of working together instead of working against each other. Is they've made the first 2 years of medical school pass-fail. I don't know if you've heard about that.
Come again?
They've made first 2 years pass-fail. So there isn't ranking.
Yeah. So there is no G and E and whatever.
First 2 years, no. Either you pass or you fail.
Cool.
Yeah, which is good. And you could see people willing to share their notes, and having somebody, a scribe, write their notes, because they're good at writing notes that are well organized to the entire class. And we have someone here on board who used to do that for her class.
Have you heard about what happened yesterday or a few days ago? I don't know if anyone would like to explain. Is Samah around? Can you?
Samah?
Yeah, there's, if I understood correctly, there's this. Yes. Go ahead. Without mentioning names, although he's famous.
No names.
Sorry, my connection cut off when you asked the question, though.
What happened with the notes thing? The guy.
Oh, yeah. An incident happened. I guess it was at AUB 2 days ago. Somebody entered a WhatsApp group, and it was for a pre-med course, and he sent the answers for a pre-lab, and he told them that I got a 93 out of 100. And 3 people ended up copying the answers as they are. And they ended up with a grade that is, I guess, 2 out of, it was less than 10 out of 100.
So speaking
So
of the
yeah.
pre-med culture, kind of everyone is trying to get the others to fail in a way or the other. That was hilarious.
Yeah. Now he's wanted, dead or alive.
I think more dead than alive, but
So yeah, cooperation more than just competition. That's the
yes, collaboration, teamwork, because at the end of the day, if you think about specialization in medicine, and it's becoming even more complex with technology and everything, and the pace at which the service is delivered, if you don't have proper teamwork at your institution, you fail. And you need to ingrain that in the minds of the students from day one. You need to work as teams. These are going to be your colleagues. You're going to work with them. You're going to work with your nurse. You're going to work with your floor clerk, with multi-level of trainees. The fellow, the student. You need to call the dietitian or the nutritionist to consult him or her on something. The pharmacist. It's a team product. Healthcare is a team product. It's not a solo thing. Okay, I know patients come into your clinic, but then they had gone through the secretary and the nurse before coming in, and then when you're done, you're gonna write a prescription that's gonna be dispensed with at the pharmacist, and you might prescribe physiotherapy. So it's not a one-man show, and we have this paternalistic culture in Lebanon, and the doctor is everyone and everything, and they're just so revered. Okay, revered, fine. Respect is great, and we need to maintain respect, but it does not in any way diminish the functions of the rest of the healthcare team members. That's why now كمان there's shift in delivering medical education, not only to encourage healthy collaboration, but also giving interdisciplinary courses. So nursing with medicine, they learn one course whereby they collaborate together to give one product. So that being said, and I don't know who that person is and why he did this very unprofessional and unethical act. I have no idea why he did that. Maybe it was his own pleasure. Or maybe it was something personal, a vendetta, ما بعرف. But it really saddens me. It really makes me very sad. Back in my days when I was in pre-med, although the competition was high, I never asked anyone about their grades. I didn't care. I just wanted to look at myself and what I'm doing. And if I'm doing something wrong, then I had to fix it. And it did help a lot because, you dodge off the negative energy. Then you were asking, there was the second half of the question, I completely lost it.
I forgot. Is it something about what do you do in economic crisis situations where everyone
how people are living
already fleeing the country?
And some people are leaving. Obviously, socioeconomically, it's very challenging to stay here. They're thinking about their safety, the safety of their families, their children, and the future of their children. If things continue to be like that, they cannot make meets end in terms of securing a safety net for their kids or themselves. So, I mean, I don't know how many are going to continue to leave, but so far I think it was around 300 physicians, which puts the healthcare sector in a very unhealthy spot. As you know, it's one of the most solid sectors we had in Lebanon, and it attracted a lot of patients from the region, and we produced good physicians grossly. I don't know what the future holds. I don't know what the future about the whole healthcare sector and how it's gonna pull itself out of this crisis. I hear a lot of hospitals are gonna reduce their bed capacity because they cannot maintain a certain volume of beds occupied, there isn't enough patient load anymore. And some physicians are choosing to spend some time in other countries whereby they can actually make fresh dollars to support their income, and then they get back here and cater for their patient population in Lebanon, which is it's a good midway solution.
Win-win kind of, yeah.
Yeah, I mean, instead of completely deserting the country, they can, find a way to go back and forth in between, let's say, Lebanon and, I don't know, Emirates or Saudi Arabia, which are usually the targets for that. And then they get back here. It's the only way they could find to, it's like a workaround. This is what's happening for now.
And given that you work in med ed too, do you have anything to say about, on the one hand, bioethics, on the other hand, humanities in medicine? Like, because you were saying interdisciplinarity, of course, getting to work with nurses and other healthcare workers is good to get to see how the dynamics go, but there's also another element there, just like you said now, and what he did was unethical, or how is there anything being done in that respect, or how do you channel that? Because I teach bioethics myself, and when I do it, it's from a completely different perspective, because we're just theorizing and we're talking, theory. But you're there. You have to make decisions, and you have to teach other people how to make decisions, how to do these things. I don't know. It's like, so it's whatever you have to say.
Well, ethics begin at home. That's not something that I question in any way, even if I don't have the evidence for it. I believe in it completely. Ethics begin at home. So when you receive students into your medical school, you have a product of experiences that have occurred at home with their peers in university and their community. So I think by the time they are matriculated, it's already too late to make major changes.
Interesting.
Yes. So for me, it has to begin earlier, and hence there has to be an open conversation with the pre-med part. The people in the pre-med who teach pre-med. This is speaking as an American system, obviously. Yeah. That's number one. So the conversation has to be ongoing, and there has to be alignment between what is hoped for by the time they graduate with their BS or BA degree and what you want once they are applying for for a medical school. There has to be alignment in the competencies of bioethics among other competencies, so attitudes and such. And the values of bioethics need to be instilled earlier, not just during medical school. During medical school, they have that already. They have threads of professionalism and ethics that begin from year one up until they graduate, and it's supported by patient experiences, patient shadowing, reflections, you name it. There's a lot of ways to teach bioethics, but the number one way to teach bioethics is by role modeling. You don't teach something on paper and create an elegant learning experience about bioethics, and then you model something completely different. You cannot expect this cognitive dissonance that you're creating. I mean, that's not okay. And it's like, when you're raising your child, you can't tell them it's bad to drink soda and while you're holding your cup of Coca-Cola. And it doesn't work like that. So that's just to put it in very simple words. And also there's that bottleneck when you have people applying to medical school. The application process, I don't know if people should put so much weight on cover letters or letters of intent, because you can write an amazing essay or you can have someone write it for you, and there's an industry
for you. Yes, there's an entire industry there.
I hate that. I think the interviewing process needs to be done differently, and it needs to be given more weight
weren't they doing that already? Like I heard
They've done, yeah, they've done
shifted
the first run of multiple mini interviews in AUB. I don't know about other schools, but I think they have to do maybe more of these, what they call behavioral interviews. So they ask you about sharing previous experiences, what have you done, and engage in longer discussions, because the multiple mini interviews are like stations, and like they're 7 to 8 minutes long, and they rotate among various people. And from what I know, this requires people, the assessors or the people running the interviews, the interviewers, quite a bit of experience and agreement, so that the whole final decision is based on a solid assessment. So, you know, people who are still not well versed with the process, you know, and not well experienced in how to assess someone very quickly on the go, may not give very accurate assessments despite month training. That's how I see it. I don't have numbers on what has happened in AUB and how well it went, because I had left by then. But for me, I have a sense that if you do behavioral interviews that are longer, and you know, there's longer interaction with the interviewee, this could be better. So I don't know. I'm still in the process of figuring out more about this.
It's a tricky thing, because there's always also things when it comes to the prescriptive drugs that and you know, the big pharmas. I don't know if he's around, but and there's a lot of things going on there in the background that we don't often talk about.
What about big pharma specifically?
Where doctors getting freebies from drug representatives who tell them, if you prescribe MedReps, yeah, if you sell this drug, you'll get this or that. This is related also to bioethics. I mean, I would understand it up to a certain point, because if they don't make enough money and then there's a lot of competition, then they would start making all these deals on the side. And when patients start questioning, because I always see it on Twitter, right? You have, on the one hand, a group of people who are suspicious of what their doctors prescribe, let's say. And then on the other hand, I understand why they might be sometimes suspicious. It's like, why this drug? Why can't it be something else? And when they question, it's like, you're questioning my authority. I'm the doctor here. You know, so it becomes a very tricky situation, because if you question the doctor, you're doing a bad thing. But at the same time, some doctors might be, you know, doing things for their own benefit at the same time. So
the issue with the pharma companies are so huge, and they pervade everything in the healthcare system, and even the research output. So you could see research about a new molecule that is produced or being experimented upon in a pharma company, and they want to run research on it, and they sponsor the research, and they pay the physician to use the patient population, not use, I'm not going to say use is a bad word probably, to actually collaborate with that physician, because he has, let's say, let's give an example. Let's say you're an oncologist, you see patients with leukemia, right? And there's a specific type of leukemia that does not respond to the traditional chemotherapy. So there's the new molecule made by company X, which is known to produce chemotherapy. And they want to test it on the population, see these people who are not responding, maybe they will respond to this drug. So there is an element of bias probably. On the daily, with the less complicated cases, so if I prescribe this cream versus that cream and has the same ingredient, yes, I think people can question that. This is why it's more important to focus on genetics. So I would like you to have a cream with that specific active ingredient. It could be this or that brand, I don't care. But when you see physicians insisting on a brand without being able to properly communicate their choice and justify it to the patient, this is when they should, they have the right to question them. I think the way the question is paused can be changed from the patient side, and to really gauge whether this is something of the doctor wanting to make benefit, or is it just because they have a preference based on experience. Sometimes you have the main drug, let's say, I'm going to give it, this is just for an example, illustration, Augmentin, which is amoxicillin clavulanic acid, is a well-known antibiotic. And then after years of its production from the main company, there are generics, because, for the, they have a patent, and then after, 20 years, others can produce something similar with different brand names. So if I say I'm insisting on Augmentin, then you would tell me, doctor, why don't you give me Amoclan or Julmentin, which are the same active ingredients? I might tell you, from my experience with my patient, they've had, I'm just giving examples here, I'm not bad-mouthing other drugs. They had side effects with that, and I don't want to take the risk. If you would like to take the risk, then fine. So you see, this kind of conversation is different. So I think also if doctors are not being very clear about it, we need to intervene in terms of training, teaching them how to better explain to patients, because we always speak about the co-production of health and co-production of knowledge. So we produce the knowledge with the students, and then them as physicians, they produce the health with their patients, right? We teach them about that, but also I think patients need to be given some awareness and know this is how you pose the question. Not everybody knows how to do it, and to really hit that specific area.
Sometimes they get offended with patients' questions, and they just simply want to know, and the doctor automatically just chews them off and let me do. There has to be the trust kind of thing.
Yeah.
Zahi, and if anyone else has any questions, please write them down. We will start wrapping it up shortly. Zahi is asking if he doesn't know whether the question can be asked, but since you are in the field, are doctors required ethically or by law, or in your opinion, to explain what a medicine drug does to someone's body, like literally how it works, not just the consequence of its use or the purpose? So it's like, where would the transparency of information come in on telling patients the truth, kind of thing?
Listen, there are two sides to this. They're not required by law, but they're required ethically to explain everything. So if you come to me and I give you a prescription drug, and I tell you, this drug, it's processed in the liver, you don't want to know that. It would become too complicated for you. I would tell you the purpose of the drug is to kill this bacterium or this virus, or to reduce the inflammation by whatever mechanism, because mechanism is not something that you're going to understand. You're not someone who's, unless you're in the scientific field, then I can explain to you better. And because of the way it works, it might cause these side effects, but I will tell you the percentages. The problem is in Lebanon is once you tell people about the side effects, this is where their focus becomes, is on the side effects, no matter how minor or minimal or unlikely they are. At least this is what I face as a difficulty. Like if I want to tell a mother about the side effects of an antibiotic, or something as simple as Profinal, which is an anti-inflammatory, that it might cause inflammation in the stomach, they're like, oh my God, I don't want to give my baby that, So probably there has to be a better way. Now, I'm still learning on that, especially with parents, it's very tricky. But it is our duty ethically, yes, to tell them what to expect and how likely it is that it would happen. And also, I think the even more important is provide reassurance. So anything should happen, I'm available. You can call me, I'm going to respond. If I'm not able to respond, you can call ER at this number. So they know they have a plan should any side effect occur. I think this is also important to be communicated. My experience as a patient a couple of months ago, I went to my dentist and I had a procedure done. And once the anesthesia started wearing off, I had excruciating pain. I started crying. He didn't tell me it was going to be this bad. So I texted him, and he told me, get this medication. And I'm like, why didn't you tell me before? He's like, yeah, it's the glue that I use. It has a bit of excessive acid or something. Like, tell me ahead of time, I would have gotten the medication, because I ended up crying because of pain. So it's not like I wouldn't have done the procedure, but I would have liked to be ready for it. So, yeah.
Interesting. So this is taking a different kind of shift now, because we got automatically to a no resuscitation. Is there is there a no resuscitation law in Lebanon, and what's your take on it?
I'm not sure. I don't think there is. This is a very tricky and thorny topic, and I don't think, because of the nature of Lebanon and how we link everything to religious practices, and I don't think that such law does exist. If anything, it's the opposite. And my take on no resuscitation, I don't have a take. It's for me, it's still a personal struggle. I'm still figuring out what I believe and don't believe about it. So,
see,
yeah,
that's the thing. As a medical doctor, like, what would you do in this case? Because there's this Kevorkian, I think, the medical doctor in the US who was, this is the other approach of assisted death, who was helping his patients die. So it was a personal decision, even though it was against the law, and he was eventually jailed. So how does I am personally interested in your existential crisis, if you ever come across these issues. Like, what the hell would you do? These are not simple decisions. So would you just tell them, go do something else? Or, like, from a doctor perspective, we always talk about the patient's perspective without understanding that a doctor is also a human being who's making very tough decisions. So
the no resuscitation decision is not made solely by the physicians or the healthcare teams. It's made in agreement with either the patient, if she or he are conscious enough. يعني مش عم نحكي حدا intubated, maybe someone who has terminal stage cancer, and they've done all kinds of treatment and they're not responding, so they're on palliative care, so just something to minimize the pain and any unease happening. And they tell you, doctor, if I stop breathing, please do not resuscitate me. And they sign for that, right? Okay. Or their family, in case the patient is unconscious. So by proxy. Now, from a physician's end, I will tell you from an experience. So I was rotating in the neonatal ICU, intensive care unit, a few years ago. And we had a baby who was born with major heart defect, okay? And it was not picked when the mother was, doing her follow-up with her doctor before she gave birth. So they took him down to the operation because, the side effects were very major, and this baby could not survive without an operation. So they did the first operation, and things did not go as well. So he arrested, and we did all we could do, but then he stopped responding. He just stopped responding despite 2 hours of continuous chest compressions, and he was already on medications to elevate the blood pressure and everything, and to stimulate the heart. So I was standing there, and there was my fellow who was more serious than I am, and he could not stop doing chest compressions. So I'm like, the baby was dead. So, like, stop. I told him stop. I don't know how I collected myself enough, because I had tears in my eyes because the baby died. I mean, we were there all night trying to keep him alive. And I'm like, because maybe I imagined that this was my baby, and we were giving him all these compressions and the trying to keep the airways open and everything, and he wasn't responding. So it wasn't easy. There was no discussion with the parents because they wanted a full code on the baby. So in case he arrested, we wanted to keep him alive and just to revive him, or anything, not revive him, just resuscitate. But that moment was very I mean, I started questioning whether we should have continued to resuscitate for around 2 hours or maybe 1 hour, something like that. So it was prolonged. Did we have to torture his body, his very tiny body, that long? Should we have stopped earlier? Yeah, and I don't know. I mean, that's my experience. Yeah.
Yeah, that's why it's. I think we almost always forget that, and I just recently finished giving a bioethics course. I don't know if Roman is still around. He was yeah, he's around, and Suhad. And we were discussing this, and it's very tricky because we ended up spending 2 hours discussing the existential state of the medical doctor themselves. It's tough. Like and this is why I don't understand how you guys do it. It's like it's not something I would want. I don't want to be in your place, right? And we always forget that there's that aspect to it. Like, yes, a medical doctor and the prestige and the status and whatever, but then you're dealing with sick people, and you're taking decisions.
You do save lives.
That's the happy part as well.
Yeah. But
we can end it on a happy kind of note eventually. Yeah.
Having somebody's life depend on what you do or what you do not do and how you do it. That's, I mean, sometimes because you love so much helping people who are in dire need of help, and because their health, which is the most precious thing, is at stake. This is medicine. This is really medicine. This is what medicine is all about. I could tell you, I remember also I was on board of an ambulance. We had to transfer a premature baby who had a syndrome and also had major heart defects. He was operated upon, and we had to move him in the ambulance from Beirut all the way to Baalbek. And the ventilating machine in the ambulance delivered very high pressures, a lot of volume of air. So we could not keep him on that machine. It was too much for his tiny little lungs. Otherwise they would have exploded. So what happened is that one of the Red Cross people, he used that, they call the ambu bag, the one that you put on the mouth here and then you start pressing for air. He had to do that manually, all the way from AUB to Baalbek. Wow. And my eyes were stuck on the monitor because every time there was a bump on the road, his oxygen levels would drop and I'm like, oh my God, he's gonna die. I was
Whoa.
I mean, you have no idea. You have no idea.
And I am not sure I want to know. That's why it's. I always have this. It's. I think these things need to be talked about more in public because people. Yes. I don't think. Maybe yes, maybe not. Maybe people want to not or be in denial of all this, but it's tough.
Maybe not necessarily in public, or with everyone else, but maybe people in the field, just to have these healthy exchanges about their experiences, and maybe somebody will come up with something, and then you could maybe why not have compile them, and at some point they might come out with a multiple like a bunch of options or choices that give you reassurance yourself as someone who's putting yourself at stake to save others. No, why not?
I always mention this because in one of the courses bioethics I taught, there was this student who volunteered for the Red Cross. Mm-hmm. And then the entire paper was about that, and it gave me a completely different perspective because there was, just like in your case, an ambulance and they had to save someone who had a motorcycle accident. It was, yes, it's a different perspective. It puts things in perspective in a way that is not, I don't know if, like before, I never thought about it this way. I cannot explain, but it was, it's seeing it in action described from that person's view who actually is involved was a bit powerful. Are you telling the patient the truth irrespective of how harsh it is? Suhad is asking. And ignorance
Yes.
is a bliss sometimes, someone is telling me in private.
Yeah, it could be, but there are ways to tell the truth. I don't think you can import communication ways from other cultures and force them onto your culture. I remember very clearly one of she's a family friend, and she was telling me she was being, her mother was being examined by a physician who was, trained in the US, and they were using the ways of very direct communication with her and her mother, and she was very uncomfortable with the way she was addressed. There are ways to break down the news that you can imbibe a little bit with the cultural elements, not the bad cultural elements, the bad habits that we acquire and that we take so religiously, but the good one, because we're a small country, we're a small society, and we're kind of close, and we tend to have these very prolonged relationships with physicians, so it becomes like a more a family friend. You can meet for lunch, or you befriend somehow. So your expectations from that person become different. It's not like a very professional or strictly professional rapport. It's a bit different. So I think we need to also identify these caring elements that we have in our culture, and imbibe our communication styles with patients with these elements, while also taking into account the standards of proper, clear communication that helps patients be compliant and come back to us. Because it's how you communicate that makes the patient, it helps them become compliant to their treatment and make the treatment journey successful.
Interesting. I don't know if anyone has any other last question before we wrap it up. Did someone say anything?
No.
Oh,
I don't know.
okay.
I don't think so.
I thought someone. Okay. So yeah, thank you, Sonia, saying for the informative talk and the discussion about ethics, and Pierre is thanking you. So seriously, thank you very much. This has been very interesting. If I end up giving bioethics next time, I think I will be inviting you to also give a
My pleasure.
talk. Thank you very much for doing this. It's been really informative.
Thank you for hosting me, and thank you everyone for attending. I really appreciate your presence today.
Have a nice weekend and a lockdown. Cheers.
Take good care. Bye.